Hello, everyone. Greetings from Boston. My name is D.Talmor from Beth Israel Deaconess and Harvard Medical School. And the topic of this talk is transpulmonary pressure-guided ventilation. Does it make a difference? These are my disclosures. The only one that is relevant is I've done consulting work for Hamilton Medical. So a lot of ink has been expended on the risks and benefit of PEEP in mechanically ventilated patients. And I think by now it's well understood that higher levels of PEEP applied randomly can be harmful. We can see patients in whom we increase the PEEP, that increases the plateau and driving pressures. These non-recruitable patients will definitely not do well when pushed to higher levels of PEEP. On the other hand, there are patients who are recruitable in whom increasing PEEP will recruit lung, open alveoli, and lead to improved lung health benefit greater than injury. And the real crux of the matter is identifying those recruitable patients and not applying high PEEP across the board. So we have postulated in the past that the way to do this is using the concept of transpulmonary pressure. So instead of titrating the ventilator to the airway pressures, we use the actual distending pressure of the lung, which is the airway pressure minus the pleural pressure. And the pleural pressure is estimated using an esophageal balloon. When we look at the transpulmonary pressure, the PL on the x-axis there, you can see that it is substantially different from the airway pressure. And by titrating our mechanical ventilation to transpulmonary pressure, we may improve outcome. And this paper published 12 years ago now did seem to support that, using a strategy of esophageal pressure-guided ventilation versus empiric low PEEP, so the ARDS PEEP FiO2 table, in an adjusted analysis seemed to show benefit in 28-day mortality, as well as various markers of lung health. So obviously a small 63-patient trial is not proof, and we launched a second trial, which was published last year. So this paper, published in JAMA, compared esophageal-guided PEEP to empiric high PEEP, okay? Because the question that was often asked is, well, if esophageal pressure ventilation leads to higher levels of PEEP, why don't we just deliver higher levels of PEEP empirically? This paper showed absolutely no difference between esophageal-guided PEEP and empiric high PEEP. You can see essentially an identical curve on the Kaplan-Meier curve, and this disappointing result seemed to say that we can just give empiric high PEEP. But does it really? So is ventilation guided by transpulmonary pressure dead or alive? And in this cartoon, the veterinarian goes and says, "About your cat, Mr. Schrödinger, I have good news and bad news." So perhaps esophageal pressure, like Schrödinger's cat, is both alive and dead. First of all, we should remember when we look at this question that Epivent II was not a validation study of Epivent I. The control arms were very different. So Epivent I used the standard PEEP FiO2 table used by ARDSNet, while Epivent II delivered much higher levels of PEEP. And you can see a comparison of those levels here in this chart. The levels of PEEP to FiO2 delivered in Epivent II, there on the left, you can see that at any given level of FiO2, it was a very high level of PEEP. If you compare that on the right to PEEPs used in the community, as demonstrated in the LungSafe trial, these PEEP levels were much higher than people are using typically in the community. So the control arm was not standard care, wasn't usual care. It was designed to test the hypothesis that empiric high PEEP was as good as esophageal balloon guided PEEP. And you can see that one issue with Epivent II is that the higher levels of PEEP delivered in the control arm actually were very close to the esophageal pressure guided arm. that was very different than the Epivent I trial, where there was a large difference in the delivered PEEPs and in the delivered transpulmonary pressures. So we did not achieve separation over the first few days in the Epivent II trial. Now, while we didn't achieve separation in the transpulmonary pressures, you can see here that there was a wide variation. So that variation could lead you to think that there may be signal lost in the noise of the larger trial. So the patients in the esophageal guided PEEP arm were all clustered around a transpulmonary pressure of 0, and the patients in the empiric PEEP arm had a wide variation in their set PEEP. And this opens us up to examining the results of the trial in a different way. And there was this very interesting paper published in the Blue Journal this year, identifying clinical research priorities in adult pulmonary and critical care medicine. And here they suggested that for critical illness syndromes such as sepsis or ARDS, research should focus on understanding the clinical, physiologic, and biological underpinnings of heterogeneity in the syndromes and treatment response to improve the development of targeted interventions and the design of clinical trials. So we should be looking at differences in our populations and identifying patients who may benefit. And I apologize for this, but they're overlapping. But you can see here that the observed versus predicted rate of death is here. Now, there are deaths related to the disease, in our case, ARDS, but there are deaths not related from the disease of ARDS, and that's the underlying deaths related to whatever brought the patient to be ventilated, so their sepsis or their trauma or so on. And depending on the ratio of deaths from the disease, some of those may be prevented by the treatment, which is targeting ARDS, and some may not be prevented by the treatment. So if the underlying mortality is high, the effect of our treatment has to be very large because it's targeting only the excess mortality related to the ARDS. And here you can see that graphically. So on this side here on the right, the mortality due to ARDS is low, and our ability to influence that mortality by an ARDS treatment is actually pretty small. Over here, the mortality related to the disease, the target disease, in our case ARDS, is high, and therefore a treatment which intervenes on ARDS may have a larger effect. I would argue that the disease attributable mortality in ARDS is actually relatively low compared to the attributable mortality of the underlying disease which brought the patient to the ICU. So in these ARDS, which is a relatively poorly treatable disease, all we know to do is to support the patient. We have to show a very large effect in order to be able to demonstrate a difference. And furthermore, we have to ask ourselves, is the therapeutic target present more in high-risk patients than in low-risk patients? And I would say that in ARDS, the critically ill patient is more likely to be sick if they are at the higher risk area. So really, we're targeting these high-risk patients in critical illness who have ARDS, but we're dealing with a low treatable disease. So what did we observe when we looked for heterogeneity of treatment effect in the Epivent II trial? We found that the lower Apache score patients actually benefited from esophageal guided PEEP, that those patients in whom the risk of their underlying disease was relatively low, their benefit from treating their ARDS was high. On the other hand, the higher Apache patients, those more likely to die for reasons other than ARDS, those more likely to die from the underlying disease which brought them to the ICU, those patients did not benefit from higher levels of PEEP guided by esophageal pressure. So looking at the results of the Epivent II trial, it's quite clear that there's a heterogeneity of treatment effect, that patients who were at high risk of dying from their critical illness didn't benefit from this intervention because they were going to die anyway, while those who were less sick from their underlying disease, in whom the ARDS was contributing more to their possible mortality effect, the treatment of their ARDS using esophageal guided PEEP did benefit those patients. So if we look at the attributable risk for death in ARDS, you can see that there's the risk of death from ARDS, there's the risk of death from their non-ARDS disease, their sepsis, their baseline mortality, their trauma, whatever brought them to the ICU. Now, if you look at the low Apache score patients in whom the non-ARDS attributable risk was low, those patients demonstrated benefit. There was a significant benefit, a significant reduction in the ARDS attributable risk. However, in the high Apache group, the mortality rate was so high, any benefit from high PEEP guided by esophageal pressure was lost in the signal. Now, this may be demonstrated in other trials. So here we see results from the ART trial. So the overall result of the trial was favored low PEEP. But if you look at the less sick patients, those with an SAP score of less than 50, you can see that those patients actually did not benefit from lower PEEP. And in fact, if this trial had enrolled those patients specifically, perhaps they would have benefited from the higher PEEP. So personalizing mechanical ventilation, what's the take-home message? Well, the clinical question was answered. Empiric high PEEP using transpulmonary pressure empiric high PEEP was equal to a strategy of titration of PEEP using transpulmonary pressure. But the question is, are you willing to use empiric high PEEP? Most people aren't. The strategy may still be superior to conventional levels of PEEP because personalization makes sense. And again, most people aren't willing to deliver high levels of PEEP, but there are specific subgroups which may really benefit. There's a heterogeneity of treatment effect, and patients who are less sick from their critical illness, as signified by a lower Apache score, may have more opportunity to benefit from an intervention targeted at their ARDS. And that's the real take-home message from my talk, is that we have to look at this heterogeneity of treatment effect in all of our interventions for ARDS to make sure that the signal of the benefit from those interventions isn't drowned out in the high noise of the high mortality from the underlying disease. So esophageal guided PEEP improves survival when risk of death is mostly due to ARDS. So that's a possible interpretation and needs to be further explored. Thank you.